everyone, I hope and I believe you all are doing great. This is Dr. Arya, your pathology faculty. Now we will be starting a new series of your skin disorders, of your skin disorders. See, skin disorders is neither too important and it's like some of the questions will be asked, either the question can be asked or either they are not asked. So I will just make sure to teach you what are the important topics that you need to understand in skin disorders. So we are beginning with a very important topic, that is the topic of psoriasis. So what is psoriasis? Psoriasis is basically chronic immune-mediated skin disorders characterized by hyperproliferation of keratinocytes. See, keratinocytes are a type of cells which results in well-demarcated erythematous plaque with silvery white scales. You are able to see this figure. You are able to see some white deposits. These are nothing but your silvery white scales, and you need to remember certain keywords, right? So in psoriasis, the first keyword that you need to remember is the silvery white scale. Let's see the definitions once again. Psoriasis is a chronic disease, immune mediated, when the immune system is activated, when the immune system is not responding properly, so the person is likely to develop this kind of disease. It results by the hyperproliferation of a cell called as keratinocytes, right? Let's talk about the epidemiology. See, the prevalence is around 1 to 3% of the population. It peaks at the age of 20 to 30 years and later on it peaks at the age of 50 to 60 years. It affects both the genders equally. It is not gender biased disease. It affects both the genders equally, and the familial tendency is 30 to 40%. If I talk about the etiopathogenesis, then you have the first thing, genetic factors. In genetic factors, you have first thing is the HLA association. So it is associated with 𝗲𝗵6, which is the most common and early onset, and HLA-B13, B17 and DR7. And I have taught you a whole new mnemonic on HLA, if you remember, right? So if you don't remember, just go to your immunology section and there just see where I have taught you that mnemonic. Next, it has the immunological mechanism, that is you will be having a autoimmune T cell mediated disorders. T cells basically come into the actions. The key cytokines are TNF-α, interleukin-17 and interleukin-23. What is the pathway? You have the activation. Firstly, there is activation of dendritic cells. After that, what happens? There is release of interleukin-12 and interleukin-23. After the release, there is activation of T helper cell 1 and T helper cell 17. After that, the T helper cell 17 releases the interleukin-17 and interleukin-22, which stimulates the keratinocyte proliferation. What are the epidermal changes you are able to see? There is increased epidermal turnover rate, that is from 28 days, it goes to 3 to 5 days only. Then you have abnormal keratinizations, that is parakeratosis. There will be excess amount of cells that will be producing. You have something called as the Auspitz sign. See, Auspitz sign is very important in case of psoriasis. So just remember Auspitz signs. What happens is, in Auspitz signs, there is pinpoint bleeding when the scale is removed due to dilated dermal capillaries. See, this is the area where it is affected. Like if in my hand, this is the area, it is affected, it is red at all. And what I do is, I don't know why my mind is just getting the signals to remove the plaque. So what I do is just remove the plaque. And when I just remove the plaque, I am able to see a lot of bleeding that will be coming out from this side. Same has been shown in this figure as well. So you have the pathology, that is histopathology. Before that, let me just show you some layers that you have. So for the mnemonic, layers of epidermis, right? You have a mnemonic of come, let's get sun burn. Come, let's get sunburn. So, come is for stratum corneum, then you have lucidum, then you have granulosa, spinosa, and basal. Okay, so come, let's get sunburn. This mnemonic you have to remember. Now, what happens in the epidermis layer? There is acanthosis, means there will be a thickening of the epidermis layer. Like this is my area where I have psoriasis. So, the epidermis, the skin of this area will be thickened and you will be able to appreciate that. They can be elongated ridges like in the cases of parakeratosis, nuclei retained in the stratum corneum. See, this is the layer of stratum corneum. So what happens over here is in parakeratosis, the nuclei basically retains in the layer of stratum corneum. What is hypogranulosis? Hypo means there is absence of granular layer. There will be absence of granular layer. What is Munro Microabscesses? So in Munro Microabscesses, remember there is neutrophils. Munro, N. So there will be neutrophils. Okay. There will be neutrophils, abscess. See, SC is coming together. So there is abscess in stratum corneum. Okay, this is the layer of stratum corneum. So here you are having parakeratosis and you are having the Munro's microabscess as well. Then you have the spongiform pustules of this. There will be neutrophils in the stratum spinosum. So where is stratum spinosum layer? This. Here you are having the spongiform pustules. See, remember the layer, remember the mnemonic that we have read, that is come, let's get sunburned, and you will be able to remember what are the things that you need to remember. What are the clinical features? First one, there will be of typical lesions, there will be well demarcation will be present. Like if in this area I am having the psoriasis, you will be able to appreciate that, ma'am, in this area you are able to see the psoriasis, ma'am, in this area you are having the psoriasis. Okay. There will be erythematous plaque with silvery white scales that I have shown you earlier, right? I'll show you again this. These are nothing but the silvery scales. These are nothing but the silvery scales that you have. Okay. Next thing is the Auspitz sign that you need to remember. It is the pinpoint bleeding on removing the scales. Then you have something called as 𝗵𝗵𝗵𝗵 phenomena. What happens in 𝗵𝗵𝗵𝗵 phenomena? There is a new lesions at the trauma site. See, if these are my hands and over here is my trauma site. So what you will be able to appreciate now, you will be able to appreciate that, ma'am, there will be a small little change that you will be able to appreciate at the trauma site. That is nothing but your 𝗵𝗵𝗵𝗵 phenomena. What are the common sites involved? First thing, you have the extensor surface like your elbows or the knees. Then you have the scalp. Then you have the lumbosacral regions, the umbilical and nails and the genital regions. And in nails, you have a very, very special sign also that I will tell you. Okay. What are the systemic associations? So first thing you have is the psoriatic arthritis. It is association is around 5 to 10%. The types that you have is asymmetrical oligoarthritis, then there will be symmetric polyarthritis, spondylitis, and distal interphalanges, that is the DIP arthritis. So distal interphalanges will be involved, and we have seen that in the cases of rheumatoid arthritis. Okay. There will be metabolic syndromes. What are the metabolic syndromes? You know that you have to tell me in the comment sections. Cardiovascular diseases will be there and the person will finally land up into their depression. Next. So these are nothing but the types. Types of psoriasis. Let's see them one by one. The first one that you have is the chronic plaque psoriasis. What happens? It is the most common and stable plaque. It is also called as psoriasis vulgaris. Second one you have is the gutted psoriasis. It is numerous small drop-like lesions will be there. Okay, and it is found in post streptococcal infection. Okay, it is found in post streptococcal infection. Third thing you have is the pustular psoriasis. It is due to the sterile pustules and can be localized or generalized. Fourth that you have is the erythemodermic psoriasis. It is diffused erythema and scaling is present in more than 90% of the body surface area. Then you have the inverse psoriasis. It is found in the flexure areas like your axilla, like the groin, and like the inframammary area. Nail psoriasis, there will be pitting, there will be oncholysis, and there will be oil drop sign. Oil drop sign. See, like I don't have the nails that I can show you, but I can draw it for you. Okay, so like this is your big nail. Okay, over here there will be a small oil droplet like lesion. So it is called as a oil drop sign. So it is called as a oil drop sign, and oil drop sign is important for you to know that it is a case of psoriasis that you are dealing with. What are the investigations you will order? Firstly, you have to diagnose the case clinically. So clinical diagnosis is there. Then what you will do? You will do the biopsy to confirm the diagnosis. Then you will take the throat swab for the streptococcal infection. Next, you have the KOH mount to exclude the dermatophyte infections. Then you have the serum uric acid, that is maybe it can be traced. Next thing that you need to remember is about the treatment. So the journal measures is avoid the triggers, right? If the triggers are trauma, just avoid the trauma. If the triggers are stress, stop taking stress. If the triggers are drugs, then you have to see that whether this drug is causing adverse reaction or whether the other drug is causing the adverse reaction. Second thing is to apply moisturizer to reduce the scaling. Okay, moisturizer will help you because it just smoothens your skin. These are basically the pharmacological treatment. Let's just see them also one by one. First thing you will be having topical corticosteroids. They are the anti-inflammatory and they decreases the scaling. That white that we were able to see, they reduce that. Then you have the vitamin D analogs. They inhibit the keratinocytes and proliferation. Coal tar is anti-proliferative and keratolytic. Then you have the keratolytics, it removes the scales. Then you have the tyrosine, it normalizes the differentiation, and you have the topical calcineurin inhibitors for sensitive areas like your faces and like your textures. Okay. What are the complications that can occur? The first complication that can occur will be secondary infections. The patient can develop any other infections as well. Okay, there can be erythroderma, there can be psoriatic arthropathy, and there can be metabolic syndromes. Drug side effects will be methotrexate will cause hepatotoxic, and cyclosporins are mainly nephrotoxic. Okay, these are basically the important signs that we need to remember. What are the signs you have? The first sign that you have is the Auspitz sign. Right, in the Auspitz sign, what we have read that Auspitz sign is the pinpoint bleeding on removal of the scale. Then you have the Ковбнес phenomena for the lesions that appears at the site of trauma. Warnoff string, it is the pale zone surrounding the healing lesion. See, I'll draw the figure for you. I don't know whose hand I have drawn. This is the trauma site. Now what happens is, this area will be a pale area that will be called as the Voronov ring. Okay. Oil drop sign, I have already told you, the nail bed discoloration, that is also called as the nail psoriasis. Let's solve question, a very important question, although I know you know the answer to this, but just let's read the question. The question is, the Auspitz sign is characteristic of which of the following skin disorder? Is it lichen planus? Is it Pitria rosea? No. Is it seborrheic dermatitis? No. I just know one thing, that is Auspitz sign is related to the psoriasis. Auspitz sign is related to the psoriasis. That I know. Okay. So psoriasis is an important topic. You can be asked a short note. Okay. We are done with this chapter. If you are having any sort of doubt, please feel free to reach me. Please feel free to DM me. Thank you so much.